Good morning. Thank you so much for joining us today. Can everyone hear me? I'm Lisa Towers. I'm Director of Marketing for Lumina Health Partners. Today we'll present the webinar, The Business Case for Quality, Why Investing in Quality Ultimately Results in Better Financial Performance. I just want to run through a couple of housekeeping items as we get started here. Our webinar will run about 30 minutes, and then we'll have 15 minutes of Q&A where you can ask any question that you'd like related to the webinar content. All participants will be muted during the webinar. So to submit a question, you can use the Q&A box in the Zoom control panel. As you can see, the arrow is pointing to the Q&A function right there. You can ask questions at any time, but we will answer them at the end of the presentation today. As they noted in the chat, the presentation will be emailed this afternoon to all participants. So look for that email this afternoon. It'll also have a survey link in there. So if you could let us know how we did today and give us any feedback on the webinar, we would greatly appreciate it. And we'd love for you to join our next webinar, Maximizing ROI from Investment and Telemedicine Programs, which is on April 18th at 11:30 a.m. Central. And we are Lumina Health Partners. We are your partner on the journey to value. Our recognized industry leaders work hand in hand with clients to guide healthcare organizations as they optimize the performance of programs to meet the demands of an increasingly value-based care payment environment. Next slide, please. And these are our advisory services, value-based strategy, digital innovation and analytics, clinical transformation, and leadership and governance. And today our webinar topic falls under clinical transformation. Next slide, please. Today's presenters are Ann Scott-Lowen, and she is president of PSQ Advisory, and our very own John Malone, principal at Lumina Health Partners. Welcome to both of you, and I'll hand it off to Ann to get us started.
Thanks very much, Lisa, and good morning. Today's agenda, we'd like to focus on the beginning with quality improvement and patient safety, which we'll talk about why that's critical to financial health. And then John will talk a little bit about clinical variation and the relationship both to quality and to safety. And then we'll talk at the end, John will discuss a little bit about physician scorecards. Next slide, please. So it would be great timing to talk about this concept this week. As a board member at the Institute for Healthcare Improvement, this week is Patient Safety Awareness Week. And as many of you know who are listening in, patient safety and quality are strongly intercorrelated. And today we'll make the business case, John and I will make the business case for the relationship between managing quality, managing cost, and financial health. As you can see from this slide, the key business drivers that relate to leadership and to the relationship that you have to look at when you're examining your financial health, the business drivers for those, the leadership imperatives on the right-hand side, you'll see the regulatory and accreditation requirements, whether that's Joint Commission, the things coming out of CMS, which increasingly are getting, many feel, more and more stringent to meet the conditions of participation or the conditions of coverage, and then local, city, and state requirements, which are on top of the federal requirements from CMS. The public is now aware and increasingly using the web to search for quality ratings. I spoke yesterday with a CEO of a health system in St. Louis who was talking about the use of some of the commercial sites such as Leapfrog and U.S. News and World Report and Healthgrades for marketing purposes. But this public reporting is important because people use hospital compare, physician compare, nursing home compare, Joint Commission's quality check, and some of the commercial vendors to actually examine where they should receive care. And then the last section that will be driving us in terms of business drivers to relate to the financial imperatives are all around value-based purchasing, and John will define value in just a little bit, but as you'll see in a slide or two to come, there is a great deal of pressure now on managing down cost while keeping quality the same or improving quality. Next slide, please. This is an old slide. There is a similar study that was done by Moodys by Standard & Poor's as well as Fitch, the three rating agencies. This one happens to be from Moodys. And as you'll see, Moodys in 2006 demonstrated the 4 key enablers for a quality-focused strategy and how they relate to long-term positive impacts upon financial health. And obviously, you can read the slide, and you'll have copies of this, as Lisa indicated, after today's webinar. But I would just mention to you, Moodys quickly and clearly saw the relationship between an organizational commitment to quality. And when I say organizational commitment, I mean everyone from the board to senior leadership to the medical staff and all of the various people, the staff within the facility, regardless of the care setting. The second is hospital-physician partnerships. And John will say more about that in terms of the importance of physicians being on board, understanding, and helping drive the initiatives toward quality and safety. We know that information technology, the access to data, and now predictive analytics, and increasingly artificial intelligence with quality are highly correlated. And last, regardless of the national benchmarks that I just mentioned in terms of public reporting, the organization has to have its own specific goals for driving toward quality. You'll see in the center of the slide that Moodys believes that increased investments in quality result in improved clinical outcomes, which result in enhanced competitive advantage, whether it's with payers or with the public, ultimately resulting in superior financial performance and higher bond rating, which of course relates to access to capital at a lower cost. And then on the far right, you'll see the longer term positive financial impacts. Next slide, please. A couple of years ago, I sat down, it was actually on vacation, I sat down and tried to put together a framework that was in my head and that I've used in working with various health systems across the United States to understand the relationship between strategic operational planning, budgeting for quality and safety improvement, and continuous quality improvement, then hardwiring the actions. There's a great white paper by the Institute for Healthcare Improvement, Kedar Mate, and his colleagues about sustaining quality improvement. The sustaining of the gains that you've worked hard on is just as important in reducing risk to not let those gains go away. So you'll see if you start at the upper left-hand portion of the circle, top priority and strategic operational planning, and then move around the circle, the relationship between the learning from others, hardwiring the new quality improvements, and continuing the strategic focus on quality and serious safety event, which is the SSE risk reduction. Reducing risk is where many people say it's all about now, reducing the risk of not having serious safety events. Many people that I know that I worked with at Joint Commission for 10 years spent a lot of time trying to work toward high reliability and toward zero harm. Next slide, please. And I thought it would be helpful to understand very clearly all of the costs that come from these serious safety events. Not only the human cost, which as a nurse, I've always felt, is the most important. If the patient is harmed and that harm is serious or permanent. But there's also costs related to these serious safety events. People have to do a tremendous amount of work to identify the root cause analysis associated with, and it's always typically more than one root cause that caused the safety event, and then the rework to be able to fix what's wrong, the legal costs and the accreditation costs as people are redirected from patient care into fixing things, often system problems or process problems that have occurred. And then the inability to generate new business reputation. These safety events are in the press every day. We see them every day. Ultimately, these impacts result in lower profit margins. Next slide, please. So I thought it would be helpful to share with you, and for those of you on the webinar today who are trying to develop a business case for quality and for investment in this very important area, you have to put dollars and cents. There always has to be a return on investment. If you want a data analyst to help identify clinical variation, as John will speak of in just a second, or you want to be able to understand what's the financial impact of these healthcare acquired conditions. This data comes from AHRQ, the Agency for Healthcare Research and Quality, and from some data from the Joint Commission Center for Transforming Healthcare. The reference is at the bottom of the slide. I don't think you can see it right now, but you'll see it when you get the slides. For each of the HACs, the healthcare avoidable conditions that you see on the left-hand side, there's an average cost per occurrence. One way to think about this, and this is just an average, you can have CLABSIs that are actually $100,000 or more in cost, actual cost or cost avoidance, or missing revenue, an opportunity for additional revenue enhancement due to using the bed for additional length of stay. If you take those number of CLABSIs last year in 2018 and you multiply that times the cost per occurrence, you can see that pretty quickly you have a pretty decent business case for wanting to reduce or eliminate these things, these CLABSIs and these CAUTIs and these VAPs and surgical site infections, pressure ulcers, falls, etc. Next slide, please. Jerry Hickson, who is the Chief Quality Officer, Dr. Hickson is a board member with me at the Institute for Healthcare Improvement. And Jerry and I were talking one day about sustaining improvements with a group of health systems and actually pharma and payers in a meeting. And Jerry put up this slide. I asked his permission to use it. But the challenge, I think, for many of us is once you have intentionally designed and implemented changes to be sure that you improve where you can and avoid those HACs, the healthcare avoidable conditions, you've got to marry that with the professional accountability to follow the new process. Lots of times, what I had found in my work at Joint Commission and even prior to that time, people would spend a lot of time and energy developing the improvements, but then, unfortunately, they didn't follow it up with ensuring professional accountability, and I mean this all professionals, accountability to follow the new process and the new steps. Next slide, please. I'm going to give you a couple of examples of places that have actually used the concepts of quality improvement and financial measurement to understand the relationship. One example that many of you on the webinar today may be familiar with is the Michigan Keystone ICU project, which was developed and managed through the Michigan Hospital Association. They actually mirrored the work that was done by Peter Pronovost at Johns Hopkins. And the focus was to really change the clinician's behaviors using a bundle when inserting catheters, central line catheters, to prevent bloodstream infections in the ICU. They had more than 100 ICUs in the state of Michigan do this for 18 months, following the standardized bundled checklist. And you can see the financial results there, the most important being the saving of more than 1,500 lives who otherwise would have been lost to a CLABSI. Many of you know this is a very dangerous infection. But there was also a big financial benefit, saving more than $200 million in excess cost. And for every dollar that was invested in doing this bundle, this checklist, there was more than $200 saved. So this is a real example of the relationship between quality improvement, patient safety, and financial benefit. Next slide, please. A second example is a customer that we worked with at Joint Commission in the center called Petrus Valley. It's a community hospital with a couple of campuses out in California. And you'll see the relationship between the work that was done using quality improvement tools such as Lean and Six Sigma and change management, is specifically helping them with everything from the care continuum, reducing all-cause readmission rates, to patient flow relative to the emergency department, to handoff communications, to actually using Meditech, their EHR, and making sure that perinatal measures were improved for CMS submission. And you'll see the surgical site infections and the denial prevention. So there's revenue enhancement, cost reduction, and of course, significant human being harm avoidance here. Next slide, please. And as I think about and we start to move from looking at the financial impact of the overall quality and safety reductions and initiatives that people are doing, looking at the total unreimbursed cost of care, because there's consequences for patients that are not fully reimbursed, whether that's length of stay per diem or cost per case, or in the case of value-based purchasing, bundles and managed care, and then the overall health system cost that we'll now turn to John, who will talk a little bit about the relationship between clinical variation, which we know results in both excess costs as well as problems with quality, John will take us through Lumina's approach to clinical variation and to physician scorecards. John?
Thank you, Ann. Hello, everyone. My name is John Malone. I'm a principal with Lumina Health Partners, and we're going to transition now to discuss clinical variation in the context of the new value-based contracting environment that we find ourselves in. But before I jump in, I just want to thank Ann for that excellent overview of the relationship between cost and quality and how critical it is to invest in quality and the ROI related to that. And in fact, clinical variation reduction programs are just that. They're an investment in quality and operational improvement that results in significant bottom line improvements. In fact, we believe that identifying and reducing clinical variation is the next wave of performance improvement because it focuses precisely on that relationship between quality and cost. So before we jump in, just a couple of quick definitions. We define clinical variation as the over, under, or unnecessary utilization of healthcare services resulting in suboptimal value relative to best practices, evidence-based medicine, and contractual benchmarks. So in other words, anytime there's services provided that are suboptimal related to best practices, contracts, or even compared to peers using scorecards, which I'll discuss in a moment, then you're in a situation where there's variation and an opportunity for improvement. And we define value as the equation of quality divided by cost. So clearly, as quality increases, value increases, and as cost decreases, value increases. And in a clinical variation reduction program, you're ideally focusing on both. In fact, you always are focusing on both as an effort to increase value. So that was a little bit of the definition of clinical variation. Here's why it's important if it hasn't become clear yet. Just a couple of studies recently and in the recent past, the National Academy of Medicine found that about 30% of healthcare spending did not improve healthcare, did not improve outcomes. 1/3 of hospitalized patients are harmed during their stay, and about 25% of patients said their provider had to reorder a test to have accurate diagnosis. So a couple others here. In the Journal of the American Medical Association, Berwick and Hackbarth estimated that healthcare waste, which includes unnecessary treatments, makes up about 34% of healthcare spending. And last year, the American College of Healthcare Executives did a survey where 51% of the CEOs surveyed identified engaging physicians in reducing clinically unnecessary tests and procedures as a top issue. So, in my experience working with hospitals, health systems, and medical groups across the country, there's fairly broad consensus that significant variation in waste does exist in the system today. So that's why we want to continue to address the issue through clinical variation reduction. This next slide goes over goals and outcomes related to clinical variation reduction, especially in the context of value-based care. Historically, before the introduction of population health, MSSP programs, bundle payments, other value-based arrangements, the focus of this kind of work was targeted in the acute care space and focused on resource consumption, length of stay, and those kinds of things. Now, however, the focus is shifting to include the full continuum of care, where you have to bring in the primary, acute, and post-acute worlds. And the goal is clinical variation is designed to expand to include targeting reductions that encompass the full continuum of care and bring in what's important to payers, such as the Medicare spend per beneficiary or average, the increasing the shared savings payments that are available in the MSSP program, or reducing the downside risk that occurs in two-sided contracts. So there's all these various kinds of goals and opportunities to target in this value-based world. And here you can see a dozen of them or so bucketed in the expense savings and spend reduction categories, the quality improvement category, and then revenue enhancement. So there's opportunities everywhere in the continuum to address variation and move the needle on all these key metrics. This next slide covers a little bit about how to reduce clinical variation. Now, the scope of this webinar is not going to get into a large amount of detail on this, but there are what I consider to be 4 prerequisites to being successful in a clinical reduction or a clinical variation reduction program. And those 4 are highlighted here on the slide. It starts with being physician-driven. We don't want to under-discuss or under-involve the rest of the organization in this, but it's typical that most of the behavior change that ends up being required in these kinds of programs falls on the medical staff. And so it's absolutely critical that medical staff leadership, the medical executive committee, and the various governance processes and committees be involved in providing the oversight and the direction and management and communications around a program like this. So especially now that we have the opportunity to align incentives and we engage or incent physicians to improve outcomes and actually share in the savings that result from that. So driving this through the medical staff organization is critical. The second prerequisite is risk-adjusted analytics. It's important to keep in mind that doctors are very much data-driven. It's part of their DNA, if you will, as scientists. And if you're going to sit down with physicians and compare how they've done against their peers and look at their various performance across various cases, they're going to insist upon some kind of risk adjustment methodology. For example, the APR-DRG methodology looks at 4 levels of severity of illness and 4 levels of risk of mortality, and you're then able to compare like patients to like patients within a population or a DRG or some other framework. So whenever you're going to sit down and look at cost and quality on a physician or specialty level or by DRG, it's really critical to have that kind of risk adjustment involved in the process. The third critical success factor is the use of physician scorecards. Physicians by nature are rather competitive, and if you can show them how they stand against their peers on a scorecard using metrics that are widely accepted as important and agreed upon. In fact, if the physicians themselves had a hand in determining what the priority metrics would be on the scorecards, then you have an opportunity to really show physicians how they compare to themselves and how they compare to others, and it brings out the competitive juices. I've seen a number of occasions where if you initially have the scorecards blinded and then let the folks know that they'll be unblinded in a month or 2 or 3 months, whatever makes sense, you'll see tremendous improvement in the metrics because they know where they stand, and they know, especially if they're towards the bottom, when the blinders come off, they don't want to be seen down there. And in fact, the majority of the improvement sometimes in these metrics occurs in the first few months with this kind of a technique using scorecards. And then finally on this slide, we have the evidence-based best practices, the use of evidence-based best practices. You want to use multidisciplinary teams to identify and research best practices for the patient population. Most organizations have some processes in place to do this and are using, at least to a certain degree, clinical protocols and order sets. We want to make sure that the research in the targeted area that you're trying to reduce variation in has brought this kind of evidence to the table, and along with that, bring in whatever value-based contract measures are being used in the contracts. It's typical in the acute care space that there would be some cost per case or excess day information. Excess days being the difference between the length of stay average and the geometric mean length of stay that Medicare provides. Readmission rates and so on. And Ann mentioned the hospital avoidable conditions, the HACs, and there's other measures by AHRQ and HEDIS, which are typically used by payers and provider organizations to measure quality. Sometimes you can add in information around CDI, clinical documentation improvement efforts, response times to queries of physicians, can add in denial rates. There's all kinds of different items that can be added in. And so what I think I'll do next is move into the next section and talk more about physician scorecards in particular. We have 3 examples here. The first one is a very high level basic quality scorecard where you're showing for attending physicians. Of course, this is a generic blinded material. You have the physicians, and then you have discharges, case mix index, mortality, the volume of 30-day readmits, and the percentage of 30-day readmits. This is a very basic scorecard that, as I mentioned a moment ago, could include a number of other metrics typically, and this is just one of many possible scenarios that you could come up with from a scorecard perspective. The next slide then covers an example for surgeons looking at knee replacement cases specifically. So you have the surgeon name and then their discharges, their length of stay, and the average direct cost per discharge. And then next to that, a bubble plot, which is plotting length of stay and average direct cost per case. And you can see surgeon D up in the upper right, the yellow bubble is the higher cost, higher length of stay. And you can see down there, the blue one in the lower left is the lower cost and lower length of stay. We know, of course, the relationship between length of stay and these kind of hip and knee replacement procedures is not very strong. The real cost driver on these kinds of cases tends to be the implant. And so what you want to be able to do in an effective clinical variation program is have the kind of analytics that allow you to drill down further from this level of detail and drill down into specific orders or supply costs. And this next slide shows an additional drill down by physician into charge master level detail for supply items. And in this case, the knee implants have a variation in cost for them, which is pretty common. And it's pretty common for there to be a number of vendors involved with different costs and different physician surgeon preferences on for those various vendors. And so one technique is to narrow the number of vendors and renegotiate prices to get more consistency across implant costs. But this kind of drill down analysis could be done in any number of areas. You can look at all kinds of different orders, pharmacy and lab and use of radiology and so on. Very good. So that's a quick rundown of some example scorecards. And so I'll just close with a quick summary here. You know, the key elements of any well-defined clinical variation program, which again is just another way to invest in quality and generate an ROI, is to make sure that you're driving this through the medical staff leadership, that you're utilizing risk-adjusted analytics, you're leveraging evidence-based medicine, and targeting opportunities to drive performance improvement across the various metrics that are important to payers, and using physician scorecards and dashboards and evidence-based medicine to ensure you're generating as much sort of friendly internal competition as possible. So with that, I believe I will turn it back over to Lisa, and Lisa's going to facilitate some Q&A. So Lisa, back over to you.
Perfect. Thank you, John. Thanks, John and Ann, for all this great information. Next slide, please. Just coming back to our housekeeping rules in case some of you joined after we ran through these. You can submit a question using the Q&A box in your Zoom control panel. There's a big red arrow pointing to the Q&A function there. Don't use the chat function, use the Q&A function to submit your questions. And next slide, please. Our first question is, what changes in quality and safety infrastructure are happening across the country? And I was wondering if you could take that one.
Sure, thanks, Lisa. Let me start, and John, please feel free to jump in. Obviously, everyone sees the continuing daily onslaught of emails around predictive analytics and use of artificial intelligence and data warehousing to be able to inform better clinical decision-making and reduce costs and improve quality. But I would say to you that it's even more basic than that. As I saw organizations through my 10 years at Joint Commission and now as a board member at the Institute for Healthcare Improvement, it's very interesting to see how much the quality and safety infrastructure has, in some cases, either not been built at all or has deteriorated over time as turnover occurs among key positions in quality and safety, and as cost reductions occur. Sometimes the unintended consequences relate to a deterioration of that quality and safety infrastructure. Think of it like the foundation of a house. When you build a house with several floors, you have to have a foundation upon which to do your work and to have the house be stable and strong. Think of quality and safety infrastructure the same way. So the relationship between and among quality improvement, safety, assuring patient safety, managing risk, medical staff credentialing and privileging, all of those things together really form a quality and safety infrastructure that when they're going on all cylinders, I guess to use a transportation analogy, really make a big difference in the leadership and the medical staff having good information by which to manage. John, do you want to add anything to that?
No, Ann, I think that was excellent. Thank you.
Okay, and our next question is, how can someone raise awareness of the relationship between quality and financial health if all efforts seem to be focused on the bottom line?
Lisa, I'll answer that, and then John, please jump in too. But my sense is that very often these days there's a tremendous amount of effort, again, and I facilitated at ACHE last week a roundtable of chief nursing officers, about 35 of them from across the United States. And I said, it's my impression that we're back in another sort of run around cost reduction. And they all verified that that was accurate. Indeed, we're looking again, due to John's very good definition of the value equation between quality and cost, we're looking again at how can we decrease cost. So one of the things that I think is important is if you have a totally financially driven organization that candidly is not paying as much attention to quality and safety, the board's not engaged, the medical staff is perhaps not as engaged as they need to be, as John outlined. I think using the slides that we've shared with you, we'll share with you after the webinar today, to demonstrate the strong correlation between quality/safety and financial health and wellness. Some of the best systems in the United States are both cost-effective and have very high quality. Part of that is they paid attention to this infrastructure 10, 15 years ago, and they built that. A very good friend of mine who was a system senior executive in quality and safety is now being wooed by another health system because she knows how to build that quality and safety infrastructure. She knows how to make that so that it becomes an everyday activity. It's not something that is an additional duty. It's the way in which every day that health system works. John, do you want to add any comments maybe from your perspective to that?
Well, you can use a clinical variation approach where you're indicating, that you're going to be financially focused through the effort, but by definition, you're going to have to include quality metrics in these scorecards, and so you're going to drive financial performance improvement, and that's going to be, you can highlight that as the goal, but you're going to pick up a bunch of quality improvements along the way, And that actually technically will drive better financial performance, which you can demonstrate to your leadership and maybe open their eyes a little bit more to the idea of bringing a blended approach. I also think that if you're in the value-based care world and you've got a contract that requires you to increase quality across some key metrics, say, utilization of the emergency department or some of the key, healthcare avoidable conditions and those metrics that are typically used, there's a huge financial benefit to doing that and showing them how you have to measure for the benefit of the payer in this case, and that the benefits that you derive financially from doing that, and they derive as well, kind of creates the right environment for an integrated approach, I think.
And a really simple start to this is just taking that one slide with the AHRQ data and actually multiplying it with your own experience at your own setting to say, okay, we had 20 CLABSIs last year, we had 50 CAUTIs across the health system, et cetera, and taking that, multiplying it times the average cost. And although that's very simplistic, looking at that along with what John just mentioned for value-based care contracts, you have a pretty compelling business case to be able to balance, and it really is a balancing act, attention to quality and attention to finance.
Great, and this is a question for John. What do you do when a physician doesn't buy in or actively participate in improved performance?
Well, that's a great question. Typically with the approach that is used in a well-orchestrated clinical variation program, you're engaging the physicians from the top down through their leadership structure and involving them in the process and getting their competitive juices going through scorecards and involvement strategies with a lot of effective communication. So plus more and more physicians are employed by the organizations that they're working in. And so there's a lot of opportunities to incentivize and just drive change in kind of this new world that we're in. But nonetheless, there are occasionally situations where physicians just don't want to play along. And I've seen situations where we've modified medical staff bylaws to include the use of the scorecards and other key metrics as part of the expectations of the medical staff, and then using the ongoing professional practice evaluation processes and focused improvement opportunities to work with those physicians to ensure that they understand the expectations and to move them towards participation. And usually when it gets to that point and you're engaging medical staff bylaws and the leadership of the medical staff in conversations with isolated resistant physicians, things usually tend to change from there.
Okay, and then one more question for you, John. What if we do not have good analytics to use for scorecards?
Yeah, that's not uncommon. Right now, with the advancement in the EMRs and EHRs, and lots of organizations are pulling together data warehouses, data lakes, pulling in clinical and financial and claims data, and being able to provide the kinds of information that's necessary to build out really, really good scorecards and measure improvement. But not all organizations have that. And where that's missing, there are vendors out there that can come in and in reasonably short order pull in key data elements and build a platform that enables you to kind of do that drill down analysis I showed, where you can go all the way down by physician, down into the order level detail, for example. And we have relationships with vendors that are able to do that and occasionally bring them in and make an introduction so that the client can have better analytics for these kinds of programs. And sometimes it makes sense for us to facilitate the development of internal capabilities. Sometimes they'll say, wait, we've got to first build the analytics, and we help them do that before moving on and designing the program around clinical variation reduction. So there's a few ways around that, not uncommon, and it's a kind of a situation by situation approach to how we handle that.
Great. And this is for both of you, but I think, Anne, if you could answer first. What kind of successes have there been in improving safety culture for patients and staff?
That's a great question, and it's probably the most difficult of the areas to get started in, or to actually sustain and fix. There are a number of organizations that have dealt seriously with safety culture, and I would just give you sort of an overview of that. There are some great resources that are free. I brought together two organizations that I care about: the American College of Healthcare Executives and the Institute for Healthcare Improvement, originally National Patient Safety Foundation, together, and they created something called the Blueprint for Safety. And if you can't find it on the IHI's website or ACHE's website, I'm glad to send it to anybody that's interested. And it basically walks you through some of the key things you have to put into place to be able to define a culture of safety, a safety culture. The most difficult part of this is that we're socialized into what's called hierarchical behavior. And that hierarchy comes from gender-based roles: male, female, doctor, nurse, CEO, staff, pharmacist, and it's everywhere. It's exacerbated sometimes by people who have a military background, where rank and file have to follow the chain of command. And in the world of safety, one of the things that safety culture teaches us is the very strong need to actually have anyone that sees a potential weakness in the system, a barrier removed, something that could harm a patient. And I'll give you an example that actually came when I was years ago when I was at Ernst & Young in a very famous health system. The director of pharmacy would not sign off on the electronic health record because the way it was set up, it was obvious to her that the potential, not the reality, but the potential for a very serious fatal safety event could occur because the epinephrine adult dose and neonatal dose were right next to each other in the electronic, the way that the screen was set up. So these things, these ability to speak up and be able to articulate things that could be dangerous before they occur, and the ability to teach people, and there's lots of good tools to teach folks about how to speak up in a respectful and courteous manner, but not wait until wrong site surgery. I again was speaking to another colleague yesterday who said that in that system, they had 20 wrong site surgeries in 1 year. That is unbelievable, and it certainly relates to a lack of the appropriate safety prevention mechanisms, but also in some cases, we've been aware of the fact that people want to speak up, but they're afraid. So removal of that fear factor, all joking aside, is probably one of the most important things you can do for a safety culture. So it is the number one issue that health systems are facing, is to develop a safety culture from top to bottom where everybody feels comfortable to speak up and say, I don't feel safe. This is a potentially unsafe situation. John, do you want to add anything to that?
Well, that was outstanding. I'm not sure I can add a whole lot, but one thought that comes to mind is that, culture change has to be driven from the top down and simultaneously from the bottom up. And there's a role for the executives in the organization to really do a ton of communication and a ton of walking the talk on this, and really getting out there and encouraging the behavior that they want to see. So I'll leave it at that.
The only other thing I didn't say, and I should, is that in my experience, health systems where the boards are involved, where they get it, they've actually been educated about safety culture, and they demand safety culture. They start at board meetings with patient safety stories, both good and bad. That really helps enable that top-down leadership that John just mentioned.
Great, and that concludes our Q&A session for now. Next slide, please. We thank you again for joining us today. We appreciate your time. We would hope that you can look us up online. LuminaHP.com is our website. You can also follow us on Twitter at LuminaHP, and follow our company page on LinkedIn at Lumina Health Partners, and also check out our YouTube channel at Lumina Health Partners. Our webinar will be posted there probably in the next week or so, and we'll also send a follow-up email with this recorded webinar so you can view it again if you'd like. Thank you again for joining us, and we hope you have a great afternoon.